So the goals and objectives of my talk, I want us to think about Bradford Hill for those of us who were not either epidemiologists or honorary epidemiologists like I am, because I'm really an occupational physician and I do a lot of the same things as Ellie does, and I do so many favors for law enforcement that I hope I get better treatment than Ellie does from the military. But in any event, reminding us of Bradford Hill, reviewing concepts of exposure, which somehow get lost in a lot of the discussions that lay people read, that governments read, comparing study designs, looking at limitations, and figuring out how we can use evidence-based medicine to actually change behavior and reduce risk. So, temporality, I'm going to say a few words. Strength of association. I think that Ellie did a really good job with consistency and coherence. The tox people really helped us a lot with biologic plausibility. So in any event, this is just my thoughts. And I'm privileged to teach this kind of thing to first and second year medical students. In the United States, that's, I don't know how that compares to exactly to Europe and Israel, but in any event, I do get the ability to form young minds. So this slide, I want to point out on this slide, this is 2015 American Cancer Society, and the fact that brain cancer is even on this slide, it's down in the bottom, brain and other nervous system, down in the bottom. So even though it's a rare cancer in terms of cancer deaths, it's not as rare as it used to be. I also want to point out that some of the other so-called potentially related to chemical exposures, like non-Hodgkin's lymphoma, is relatively high also on this list. So risk assessment, probably we all know what's in this slide. Point of this slide is we all know what's in risk assessment, but not decision makers don't necessarily all know that you should be doing a risk assessment. So when should you use a cohort study? When should you use a cohort? Best time to use a cohort study is something terrible has happened, and then we're going to follow the people afterwards. And I'm kind of alphabetically challenged, so I get near the end of these kind of things as an author. But Roberto Lucchini, who's at Mount Sinai, really encouraged us all to put this together, and we helped him put this together. And basically, we looked at what happened in 4 different environmental disasters. Seveso, which was his area of expertise, the TCPs and dioxin. Bhopal, big tragedy with methyl isocyanate. Chernobyl, don't need to say any more about Chernobyl. World Trade, which is what I do. And I just wrote toxic soup here. There was just so much stuff. And Fukushima, most recently. So after these kind of disasters, this is when you do need long-term cohort studies, surveillance programs, and in fact the surveillance programs have found physical and mental health issues that really do need to be followed, chronic health conditions which really need to be followed, that kind of thing. So that gets me a little bit to World Trade, and in the middle of there is my police patient that I'm going to speak about, this over here is one of my firefighter patients. So you could see that you probably don't need rocket science to do a really good risk assessment that people were exactly exposed here. So what were they exposed to? The classic mixture those people who lived in the United States at the time might remember Governor Christie Todd Whitman getting up and saying, we didn't have anything to worry about, nothing really happened here, just because we had 100,000 parts per million of exposure. We had numbers like that, ridiculous numbers, crazy numbers, and there's nothing wrong with ground-up cement, except, of course, ground-up cement had a pH of 11.5, so that broke down every membrane in creation. So if you weren't going to be exposed to things, you got exposed to things. Now, the next slide is for I have a little bit about volatile organics, but the next slide is especially meant for my Italian colleague here, because I was so excited to see you mixing up your formaldehyde with your RF exposures. And I mean, we have formaldehyde is one of the many identifiable things that was in our plume. Obviously, there were lots of unidentifiable things. Obviously, there were lots of reasons why there was probably radiation there, although maybe someone would just say it's a confounder. In the epidemiology working group yesterday, we talked about short-term problems. And for those non-clinicians here, this is the ultimate before and after slide. So this is what happens. This is the New York City Fire Department, a very conservative group of people, and this is what usually happens to your lung function, usually, and they had data from before 9/11, and here's data from after 9/11, and there's this drop here. So that's what's interesting there is that we were able to show a physiologic effect, not just an anatomic effect, but also a physiology effect. So we were able to show something happened. Something happened. And then that study spurred a whole bunch of other peer-reviewed articles, and we made Lancet, and FDNY made Lancet, and we ended up in a lot of peer-reviewed journals that a lot of things happened. These are the non-cancer outcomes, but this was at least enough to get the United States government to fund us. Indeed, I was on the phone with them for an hour and a half until 10:30 last night, which hopefully means they're going to fund me some more. Funding is good. So we went from our short-term health effects to our cancer excess. We had 3 different cohorts there that were being followed. We had the New York City Fire Department. They made New England Journal because they had such great before and after data. I am part of the consortium. Rutgers is a relatively small partner with Mount Sinai and Stony Brook and NYU and what's now called Northwell and in North Shore, LIJ, Queens College. They keep changing their names. In any event,
quick question. You got compensation through cancer patients for all of those cancers, all those types of cancers?
we're getting compensation for all types of cancers, with the possible exception of female reproductive cancer. That's another argument. We're compensating prostate, but not compensating female reproductive. But that's beyond the course of this. This study was actually the first authors on this study were actually New York City Health Department. I went with the New York City Health Department people to present before. This was originally Mayor Bloomberg, and this was a really, quote, conservative estimate of cancer. And one of the city councilmen said, is that because Bloomberg is a conservative, not a liberal? And I had to explain to the city council what epidemiologists mean when they say a conservative. Tony wouldn't think that that's what that means. But the point here was that even though we showed, even though you could say that there were excesses in prostate and thyroid, which are all things that there's a good amount of screening bias, meaning that you do a lot of looking, so you're going to do a lot of finding. That's what screening bias would be. However, the New York City Fire Department almost made it, almost eliminated that because they were checking before and after, and so the screening, they were screening just as much before the 9/11 as after. So that number with an SIR of 1.43 was really pretty significant because we feel like they eliminated that. Multiple myeloma, for goodness sakes, why would anybody screen for multiple myeloma? And I was actually, two of the original cases were people that I actually, one passed away and the other's alive, but so I was involved with that. So that was a good use of cohort study. Now, I don't think there's anyone here that thinks that the Chapman study is a good use of cohort studies, but the oncology community thinks that it is, at least in the United States it does, and I don't know whether it does in Israel. I'm trying to meet as many people in Israel, but a lot of the people were here yesterday that I wanted to keep talking to about this, and I'll try and talk to them. So they cited stability of brain cancer except in males over the age of 70. Now, I bold the second statement here because they say the difference is due to improvement in imaging techniques. And so when I first looked at that, I said, well, that's something you would say for something like prostate cancer or breast cancer. That was my first thought that meant. Then I'm thinking, nah, that's probably not what they meant. They probably meant that some of the people we just thought had Alzheimer's disease had some kind of an indolent cancer. I'm not sure what they meant by that, but my oncology friends parroted this statement here to me saying this. They state it's due to improvement in image. Even if you want to say that maybe you pick up a few indolent cancers by this, I really don't see how you pick up how you could say you pick up more glioblastomas from this. So I just want to point that out. Their data was obtained upon who had the account for the cell phones. So, for example, if you were to look at my family, now my account's on Rutgers, but if you looked at this, the account was in my husband's name. I can assure you my husband had the least cell phone use of anybody in our family, but the account was all in his name. So if this is how that study was looked at, the final statement here, which has been parroted to me, is that last one, that they make this conclusion that there's absolutely no data on changes in DNA, and we know that's not true, yet this is the study that's been quoted to me by the oncology community because I've been trying to get the oncology community to buy into some of our World Trade work, let alone on cell phone work. So now we go on to the Sato study. Now the Sato study did show there was an increase in malignant neoplasms in Japan, but then they said it wasn't consistent. And then I looked at how they were measuring people, and they recruited their people by distributing leaflets in schools. And I just don't know. Is that? I could be wrong. Tony's the world famous epidemiologist here, but did that seem like a really good way to recruit people to follow just by randomly dropping off leaflets in schools? So I had a problem with that. But my problem here is that these two studies are what gets cited in the in the community as a whole, and by the people that don't think that cell phones have much effect. So clearly it becomes difficult to use these kinds of studies to establish relationships between cell phone use and health problems. And I really don't know how much how Bluetooth factors into it, and I was hoping that somebody here was going to explain to me what Bluetooth, how it actually works. So I believe we have biologic plausibility. I think the toxicologists may need to go out and get us more. And sorry that Linda couldn't be here, because I think that between the NTP and our Italian colleagues, we could probably come up with even more data to convince the non-believers. I thought that this Volko study was really interesting because, again, this shows a physiologic. I don't think you can argue if there's a change in physiology. Now, back to glioblastoma, my patient, and then I guess we deserve a coffee break. So I picked this off of Medscape. Medscape is a common place that physicians in the United States go to for continuing education. So I think it's good that Medscape even mentions cell phones, even if they say it's controversial. I think it's great that they mention it, and I think it's great that they mention EMF, because it means that somebody's even considering it. So now this one is for Ron, because you asked about recall bias. I am not presenting this case as a case that it's a great epidemiology, but rather I'm taking you into Ellie's and my kind of practice, where we do get to schmooze a lot, take interesting histories. And the other thing to say is, do people know that this is a bobblehead up there? Okay. So in the United States, people make a bobblehead of somebody that's like an icon, like a hero. Like if you're a Yankees fan, Derek Jeter was an important bobblehead. If you're, I guess, a football fan, maybe Tom Brady would be an important bobblehead. So like somebody who's an important icon in sports would be a bobblehead. I'm not going to be political and say which politicians should be bobbleheads, because I could get in trouble for that. But Bill was such a good trooper and an important trooper that he was the one picked to be a bobblehead, very well loved by his peers. In fact, when he died, Governor Christie, you could make fun of Governor Christie in New Jersey. He does a lot of things to be made fun of. He declared that the flags in New Jersey would be flown at half-staff in honor of this hero who died at 9/11 from his glioblastoma. I want to point out, I cite the newspaper here because we in the United States have something called HIPAA, where I could get in trouble to reveal personal information. All the information I'm revealing was in the newspaper, in the obituary, so I can't get into trouble. So now this guy presented with memory loss and 3 months, only 3 months duration before he was diagnosed with his glioblastoma, and described in the newspaper, described by his wife, who's a registered nurse. She was sitting outside the room watching the imaging, and when Bill came out, he saw his wife crying, and he knew he was in bad shape, and maybe he needed to meet Frank, I don't know. He was treated in Hackensack Hospital, and my role has been to make sure that everything possible has been done for him, and he died December 27th. Now, talking about recall bias. Is everybody remembering all the things that he did? Well, this guy was a famous trooper. That's why he got the bobblehead. He was in charge of communication at the World Trade Center site, meaning he coordinated the different agencies, and his wife describes that he drove in his troop car with the cell phone like this, and he's driving like that, and then they're talking to him through the walkie-talkie thing, and by the way, he gets out of the car and goes and helps with search and rescue with World Trade. But his career was to go to other places for the New Jersey State Troopers. He was a trooper for like 23 years or something like that. So he went to other kinds of sites like this routinely. And I asked his I was wondering about whether it was ipsilateral or contralateral. Now, I don't know. So there may be recall bias about how much he used it, but this was witnessed by. This was witnessed by the troopers. In fact, the bobblehead was given to me by his commanding officer, who has a different kind of cancer. And I also treat one of his colleagues who has a very aggressive non-Hodgkin's lymphoma. So I don't know. So talking about the ultimate confounders, this guy had all kinds of both cell phone, general EMF, various hazardous things at the World Trade Center site. So besides Bill, in my practice, we haven't looked at this for the whole World Trade practice. I follow approximately 2,800 people in my particular site. We have data on well over 40,000 people, but in the group, this is in the group that I follow, the 2,800 people. I have 3 cases of temporal lobe glios. I have 1 glio in the pons. I have another, well, the one in the pons is a glio, but it's not a glioblastoma. And I have another temporal lobe astrocytoma. So I'm following 5 cases now. You asked me about power calculations, Deborah. So I've got 3 glios out of about 2,800 people that I'm following, and I dare say that there probably isn't any screening bias for those kind of cancers. So again, I hearken to my Italian friends who were able to get workers' compensation, and again, using Levis's study, and I guess he testified, and this all came out of the newspaper, and again, the newspaper Journal of Medicine, so he felt like his work as a heavy cell phone user was responsible for his tumors. So where does this leave us? I think it behooves us to recruit. So as a clinician, so as a clinician, I go when I recruit the best possible epidemiologists, so I don't have to worry about the recall bias, attention to other risk factors, selection of appropriate cases, and comparability to studies of rare cancers like mesos and angiosarcomas. So these 2 slides were shown already, so I don't need to show them. So let's get our workers' compensation. Let's get the emirs of the world to improve the technical things that they're doing. Let's incorporate a little bit of prevention into our lives. And I want to say thank you to my patients most of all, Rutgers University, CDC NIOSH, who pays for a lot of the things I do, including my cell phone, NTP and NIEHS, and Linda for getting me interested in this cause, and Deborah and the Trust, but most of all, my American and Israeli families. Yes, yes.
To talk about this and perhaps to talk more publicly about it.
Yes.
As you return to the States, we want to think about this because putting the human face on this sometimes helps people understand that we have statistics, but this is a real person who experienced this.
And I wanted to say for the people thinking about this with the Israeli military, I now have some of these police organizations really interested in this, and it's probably pretty comparable kind of people. And so we have he's a New Jersey trooper. We have in our practice the Port Authority Police, the New York City Police Department, and we have very close relations with the New York City Fire Department. So perhaps we can do something for people like that.
Amen.
I was delighted when you started with Bradford Hill, and if anybody here hasn't read it, I really recommend it. However, and he calls these 9 things, he calls them viewpoints. And he said, and yeah, but at the UC Berkeley School of Public Health, it's taught us criteria, and all 9 are required. The other thing, the Chapman paper is fundamentally dishonest. He quotes a partial quote from Dobbs et al., which was already reporting a high increase of cancer, brain cancer in Australia. He had read that, but he didn't even refer to it.
But the challenge,
Tony, you might want to add to the chapter.
Can I speak? Okay. No, I would like just, Iris, know if you are aware about the study that we have performed on the World Trade Center dust at the Ramazzini Institute. Paul Loy gave us the dust, and we have the result about the lung. And we have seen, I have just heard angiosarcomas. You mentioned this tumor, among others. But are you aware that we have
you have Paul's dust?
seen an increase of that? And having us the study on the electromagnetic field and the combination with chemical and physical agent, I think that the experimental study could be of support to the epidemiological one. But we had a fund until the lung, and we have to elaborate all the rest of the tissues. So I am just arguing if you could interested in presenting a project
Sure.
together.
Sure, would love to. We can speak in break, but I was actually with Paul a few days before he died, and I got him a congressman. For people who know Paul Loy in this room, I managed to get him a Republican congressman, Congressman Lance, to come and visit us and help us in getting our program funded. And so I didn't know that his dust went to you, but Paul's,
We have published
yeah.
it on the American Journal of Industrial Medicine.
Well, I saw you were related to Landrigan already, so.
Okay, well, I want to, Ron?
So, you indicated a number of limitations in cohort studies. There's probably a lot more based on the nature of cell phone use, messaging, people using speakers or headsets. Can there ever be a good cohort, retrospective or prospective cohort study for cell phones?
So this is my thought about that. Can you do the cohort if you're looking at cancer? I mean, I don't see how you can get much of a good cohort looking at cancer. However, you probably can get, we were talking about this a little bit in the epidemiology working group, you might be able to show some of the short-term effects in a cohort study. I think for cancer, the good thing we were able to do in World Trade is actually pay for it before we had the definitive results, because we had so many short-term results there. So I feel like maybe you could use the cohorts to look at short-term stuff, but it really behooves you to come up with more biologic things to convince people. But I think that you're also going to. It's silly. Why aren't the children doing creative things with finger painting when they're in kindergarten? Why does a kindergartner need to have? Right. It's one thing. And why do people need to keep it turned on when it's not needed to be turned on? Right.
Just a comment on establishing cohort studies. There's a large cohort study in progress in Canada, and I tried to get the elements of the interphone questionnaire incorporated, and the questionnaire committee decided this was too complicated and they couldn't do it. They may or may not have been right. Anyway, I want to thank Iris and Elihu.
Got it?
Yes.
Okay.